you for the invitation. Can you all hear me well? So the idea is to talk about our experience with using data and analytics within a hospital environment and outside the hospital environments. I'll start with a bit of the experience part. We started from the proposal of collecting the data as much as we could and representing it in a three-sphere kind of conceptual model. Those spheres are always based on a single human. The first one is the biology. So we are now collecting data and organizing data from system biology. In other words, information that we can get from labs, from exams that people perform, including imaging. The second sphere is environment. So it's the exposome. How each one of us was raised, what was experienced on the surface of this planet, including air pollution, environmental challenges, education, social problems. And the last one is what we do, how we behave, how we interact with the world, so behavior data. So these three spheres are just an important way to connect the data, because sometimes the analytics, the legacy, the ethical and other components will be linked to those areas very much. So we started back in 2015. That was a 10 years long journey. I don't bother you with all these steps, but nowadays we're able to deal with data in sensitive ways, including the resources we have available in the cloud in Brazil, according to our legislation. But we managed to get not only the data somehow organized in this continuous process, but also to share the data with others. In the institution, there are now 245 data specialists for an organization that works with healthcare. It's a significant number, and we're always growing, we're always connecting. We've been working with data integration in different ways since the central database, which is most of the cases that you do when you have interaction with companies or other centers. Secure cloud, which is again, part of the scientific community is doing that. And more frequently, what we're doing now, most of the times work with federated data. So the data will not leave the institution. It's just the case that we open the data to certain access, again, totally monitored according to the law, based on a previous approval. And so it's open, but it's not public. So it's not easy to do something that's not according to it. We were part of the Odyssey, this common database model based on OMAP format. We started our journey. Now our data is pretty well organized in that format, so we're able to connect with other centers or doing research in the same manner. And that's an initiative that we recently connected also with Hospital das Clínicas and other institutions in Brazil that are doing the same idea, that's organize the data in the same format, so then you can make it easier to analyze information. We also have a partnership with different countries here, and this is an alliance in Latin America for patient safety. It's based on the Institute for Healthcare Improvement. So we are now looking at promoting data organization the same way we promote patient safety in different hospitals in those countries. What are the applications for AI in healthcare? Well, it's a long list, but just let me know that most of the things that we're doing now are not related to direct patient care. It's related to improving, making it more efficient, the way we take care of patients. Patient data is very sensitive, we all know that, and there's lots of promising for using patient data, but most of the time it's really difficult. It really requires a very careful approach, including having the patients together in the committee that will decide how and when and if we're going to use AI for direct patient contact. So this is our approach. We have a committee that contains patients, governance, and of course, the guys. This is again an interesting approach. We believe it's in the same direction. On the left side, basically, there's many approaches such as that one. It's a BMJ publication showing that we should take care of algorithms the way we take care of medication approval. So phase 1, phase 2, phase 4, phase 3, up to the same point that we're looking at something that might change patient care. So it has to be done in a safe manner. So that's on the right side of that scale over there. That basically says AI is not immune to evidence-based medicine. We have to do the same thing we're doing with science anyways. So we have to conduct studies that look for safety, adoption in a way that we know at the best of our knowledge what will be the results from the adoption. On the other side of that scale, this is management. It's not necessary to do those things. We do this anyway. In the worst case scenario, we do it by our intuition. This is like, how am I going to decide how many doctors will be on Friday afternoon looking at pediatrics in that part of the city? How's that done these days? Basically, experience, some projections, of course, of number of patients. We have historical data, but predictions very rare. So these are things that will, at the end of the day, hopefully improve patient care, but these are not direct use of AI in a patient encounter. It boosts efficacy and efficiency, and it's less of a problem. So the adoption here is the value for the operation. How many lives can I actually see with the same amount of resources that I have? And this is really important for Brazil, for the reasons we all know. Brazil is a very unequal country. However, to the point that you're asking, our data is full of bias. It's not only the case that we don't have the representation of the minorities in our database. It's just that the minorities are not using the data, so it's a different thing. It's not like we are using data from the minorities, but you have to get the minority learning how to use the data. That's a critical part. Decision making is always intertwined with human bias. We will be using a tool anyways, no matter if that tool is ethical 100%. There's always the chance that a human will not do the right thing. And the last part is a very good example. A company designed a catheter for cardiac intervention that could not be used by the population of Japan, Asia, and others, simply because the minimum size of diameter was not commonly found in the population of that part of the globe. It's just because they have smaller hearts. And why did that happen? Because all the trials were performed in another population from European countries, which is very different. Again, this is a very basic kind of bias. Of course, we can imagine that with the AI. And this is, again, what we all know, inequity. On the left side, we're just looking at the number of studies involved in cancer research, in which population those studies were conducted. Most of them were conducted in the white population, north of the equator. And of course, the number of people that live in this planet is not represented by that population by far. So the result is now that we have fantastic drugs that might work depending on people's genetic background. So they are not fitted. We don't know if they are fitted to work with our own population here in Brazil, for instance. Big problem. On the right side, it's a more interesting thing. It is, again, oncology. And this is a publication that I think is very illustrative. On the graph on the right side, it's easy to understand. The red line, horizontal line, represents number 1, which is the ratio of that particular part of the ethnicity in the study. And on the left, you see the green part is the white people. The blue one is Latin origin. The yellow one is black. And the white one is the original indigenous populations in the US. Needless to say, again, very unfair distribution. So how do you train AI in that world, which is our world right now? We have to change that case. And that slides actually were brought by Neil Anthony. I like that sentence. So if you're not sitting on the table, probably you are in the menu, meaning somebody's paying for that. Somebody's not benefiting from the menu, let's say that. Right? So we have to think about it. The way we do these things usually is what you're just hearing about. We gather data, we train the model, we try to localize the models in specific process, we look at the adoption, we look at the results, and then what we do is, again, the usual thing. We test in what is in our environment. We don't know whether it's going to work anywhere else. So, it's a Caravaggio, nice picture. We have to touch to see, I have to test. And because of that, we have to governance the data. So in our hospital, what we did was to establish, since the first year that we started that project, a governance committee that is based on those 4 items there. We believe that by building the learning curve, you can actually promote a fair culture in the institution. And there's lots of discussions every day about it. But since you start with the proposal that is a decision that will be made by all involved, that will not be too much of a problem. When you face a problem, there's always a problem. People will understand that at least we tried to do our best, and they were involved. They were part of this. Now I'm going just to share a few examples with you. This one was a very direct one. We tested the solution based on AI to look at genetic exams. So in order to see whether, by looking at the microscope, we could classify the images in a way that would help the pathologist. And actually, these are, again, efficiency methods. We reduce from 14 to 7 days, one kind of test, and the other from 15 to 10 days. Pretty significant. There was always a human in the loop. All that this person would see just a highlighted area that he or she could check, and they would look at this only after they look at the images before. So that was an interesting thing, and I like to emphasize many other projects we did. Sorry, this is in Portuguese, but basically, most of those projects took more than 3 years minimum to be in place. And as you might see there, all the results are related to practice for the automatic 7 days per month. At the end of the day, allow process 1424 medical notes automatically coded. So that enables these people to move from one job to another inside the institution. Because as I said before, since the beginning, we wanted to be very ethical. So just the question that we are not hiring people in that position, but they're moving others to other positions. For instance, this is one of the part of the studies. When we optimize the surgical center by optimization of the outcomes, that's 83 hours per month less in the patient care, and that again enables the nurses to do what they needed to do most. This is an algorithm for readmission. A big summary there, but there are many solutions we have in different areas for diagnostic, treatment, prognostic, efficiency, and most of them are in the efficiency part. As I mentioned, the number of algorithms we tested. We developed part of those, we use part of those that were developed elsewhere. And this is a panel that I'd like to show you. This is actually our dashboard for AI use at ICIN. So let me navigate you on that one. This is the, hopefully it will work. I'm using the pen. So yeah, on the left upper part, you see the number of solutions that use AI tested. More than 570 algorithms were tested since we started. On the right side, the orange one, 29 solutions. We didn't make any use of it. We tested, they were not good. Around 93 algorithms, they basically failed. On the left part, but the light blue, 40 solutions are now currently being developed. 365 algorithms are being developed in the institution. And we're using 24 solutions with AI, comprising 116 algorithms. So this is what we're doing now. And if you want to see what's going on, this is basically a live dashboard. If you click here, it's a catalog. So this is so I'll click on this first one. This is what we have, what's going on about each project. So this is the one page that contains the information related to what was the rationale, which algorithms, lots of data regarding the performance, the number of people involved. This one started in January 2023, et cetera, et cetera. So every AI is documented. The MLOps also part of the game. This is one of the screen we can use. This one is to look at a solution that has 6 algorithms for prediction of metabolic syndrome. And you see in the last month was just the performance of that AI. If that performance was above or below a certain number, we can actually ask and pull the trigger, etc. So that's continuous monitoring, continuous development. And that's the last thing. This is for medical doctors. We call this health story. This is where we get all the solutions embedded and show to the doctors. They have to sign an agreement. And this is basically, we expose them to training. So this is a LLM. One of the LLMs we tested was, of course, GPT-4. We had to do it within Brazilian borders, etc., because of legislation. We also tested many others, in total 10 different LLMs. We're constantly testing those, but we're allowing the doctors to interact, and you can type in your questions, or we can use some questions that are like, what is the diagnostic? Past history of this patient. So very basic questions, because the doctors, they want to see those kind of questions more often. So instead of letting them type things, just press some pre-prompted engineering buttons. They click this format the way they want to see. By them, they are the ones that advise. Currently, 2,800 medical doctors are using it on a daily basis. So this is basically the last part. I'll just skip and show you one thing that is for the work we do with the government. There is a project we work, and many other hospitals are involved. It's called ProAgisus. We develop solutions for the government. Every 3 years, there's a new project. In this current one, we have 8 projects. There are many different projects involved, but these are projects that are using data and AI most of the time. I hope that this can bring to the government the same experience we have, and that if you have more curiosity, there's data there. Some of them are related to trauma, some are related to environmental challenges, some are related to the environmental surveillance in the indigenous population of Brazil, some are related to ICU care. More than 200,000 patients were involved in that one. And if you need more information, you can use the QR code. Thank you.